No clapperboard, so that's it. Welcome. Wow, quite a lot of you. Just to introduce myself, I'm Henry Jones. I'm CEO of the Big White Wall. And probably a first announcement. Unfortunately, Gregor Henderson, unfortunately for personal reasons, couldn't make it today. He has provided us answers to some of the key questions that I can use to respond to some of the things that we want to talk about in this debate, and I will try and channel Gregor and give you some of those answers as best as I can. So before we kick into the panel and I introduce the two individuals here, I thought for those of you who don't know who Big White Wall is, I thought I would do a very short, just sort of high level of who we are, and for those of you who know who we are, apologies. So Big White Wall is a social impact business. We are CQC registered. We provide digital support around mental health. Our key offering, and I think one that is probably drives our particular interest in this concept of population healthcare and prevention instead of cure, is an online community. This online community is anonymous. It's accessible 24 hours a day. It is clinically monitored 24 hours a day by clinicians. The community interacts and supports itself through talkabouts, resources such as assessments, courses, guided support, etc. And ultimately, we believe provides a very safe and supportive environment for those suffering from anxiety and depression, particularly for early stage sufferers. And we talk a lot about the concept of catching people before they fall and trying to put them on different pathways. To give you a concept of that community, within any month, there are about 20,000 people on the community. To date, we've helped 150,000 people. 5,000 at the moment are signing up every month. They're viewing 230,000 page views. They're doing 10,000 posts. They're doing 8,000 assessments a month. So this is a very active and vibrant community that is growing exponentially as we speak at the moment. So growing very fast. I think some of the things that we see in terms of how people report the outcomes of that, 9 out of 10 of users say they experience wellness gains. Everything from reduced isolation to being able to cope with their responsibilities better, to being able to share problems with others, family members and others. About 2/3 of the people who come onto the platform have never shared their problems with anyone else. This is a very interesting early stage way of catching people. In terms of those who are interested in budgets and numbers, we're working on some research at the moment, but early findings, and this is based on self-declared patterns, is that for every user who visits the platform, we reckon we save the UK economy in terms of visits to the doctor and to the A&E about £250. Okay, so everyone who comes on causes reduced visits to GPs and A&E. So that's really about Big White Wall. We would love to share more if you want to know more, but you didn't come here to hear about Big White Wall, so I'm going to start talking about why we're here. So I think the interest in population healthcare, the interest in prevention is growing, and there is more and more we hear about it. I think the fact that that we've had such a high attendance supports that interest. The presentations that we've seen this morning from Duncan and Andrew talking about this issue of how do we not only look at treatment, but how do we look at the population and build in prevention, catching people before they fall, etc. And so what we wanted to use this opportunity to was really to dig into that conversation a little bit more and talk to some people who really are at the sort of the front line of trying to make that a reality. And the idea, the original, the idea of the panel, we would have Gregor, who unfortunately can't make it, obviously representing Public Healthcare England, very much at the front of driving policy and driving the progress on that. We have Janet, who will introduce herself in a minute, who is working within the NHS and is very much, I would say, doing the hard yards of trying to make it a reality go forward. And then we have Tim Rogers, who is a practicing clinician, who will be able to give it from the clinician's point of view and talking about what we're talking about. So, Janet, do you want to just introduce yourself a little bit?
Yes, hello everybody. I'm overwhelmed there's so many of you here. My name's Janet Hinds. I'm Mental Health Transformation Manager for Central Lancashire CCGs. We have a population of about 480,000. I've been with the CCG only 12 months, so quite new in role. I did work for the Care Quality Commission for 6 years before that, and what instilled my interest was working on a mental health crisis care review about 4 or 5 years ago, and the Concord Act was one of the outcomes of that. And I've been personally touched by mental health, so it's an opportunity. The main provider within Lancashire is Lancashire Care, who are currently rated inadequate, so I've got quite a challenge ahead of me. Big White Wall, it's a huge part of our community service, and I just want to say, a big thank you to Big White Wall. They fill so many gaps for us, and we hope to continue the relationship.
Thank you.
So that's me. Great.
Thank you.
Hello, everybody.
Tim?
Hi, everyone. It's really nice to be here. I'm looking forward to what we're going to talk about today. So I'm a medical doctor. I'm a psychiatrist. I work in lots of different parts of the mental health, spectrum. I began my life as a forensic psychiatrist. So I worked in prisons and in forensic community teams. And over time, I've moved into a number of different areas. For the last few years, I've been working in professional sport. So I spend a lot of time with elite athletes and other performers, dancers, who have sometimes some unique and some similar struggles to other people with mental health problems. And in the course of working in sport, we were working on a research project involving an app, and there were some really interesting things that I learned in that project about digital health and the way in which the app that we were testing at the time changed the culture of the team in which it was being shared. And so from there, I guess I also saw that how important anonymity can be when there is a huge degree of stigma about what you're going through. And for people in the public eye, sometimes, and also athletes who are told that they have to be strong and not to show weakness, anonymity can be a really important thing. And so those, I suppose, two stories that were those two themes that were in my career came together a bit when I was asked about whether I'd be interested in coming to work with the Big White Wall, and the Big White Wall is predicated on both of those things, I think. So a stigma-busting, sort of anonymous kind of service, and also delivered digitally to people and places that might not otherwise be reached by a conventional mental health intervention. So that saw me meeting Henry.
Okay. So sort of to kick in some of the questions, and I thought...
I was waiting to see if we would have a very small turnout, and then I was going to suggest we do questions as the panel goes along. But there's quite a lot of you today. So I thought what we would do is save questions to the end, and we will try and make some time for that. So the first sort of question, and I'm new to the area. I've been working at Big White Wall for 8-9 months. I actually don't come from this background. I did a psychology degree quite a way ago, but I come from from a different sector. And I've been around, and actually that's how I met Gregor, really talking to people about what is this about, what is the challenges, how do we as Big White Wall play a role in that and stuff like that. But I thought one of the interesting things was specifically to sort of try and nail, just from those who know, what is population healthcare, and this may repeat some of the stuff that was being talked about this morning. But what I thought I would do, and I was going to try and paraphrase it, but actually I think I'm much better just reading what Gregor sent me, as opposed to actually trying to paraphrase it. So the question was, what is population healthcare and what does it mean to the mental health sector? So this is his answer. So population health means looking at all the factors that influence the public's health, the good things and the bad things. Those factors that put health at risk factors, those factors that protect or help improve health, protective factors. It is about developing a good insight into local needs in a population and for working with and through others to address these factors, or as they are often referred to as the social determinants of health. Think about housing, employment, unemployment, education, the built environment, poverty, etc. as key factors that determine our health, plus exposure to an experience of abuse, violence, discrimination, our access to good, affordable food, places for recreation, physical activity, access to green space and blue water, blue space, water, all things that make up a good life. Then add in social, psychology, and emotional aspects, how people think, feel, behave, and relate. Put all of this together and you have a public health or population health approach to mental health. Action is required from a range of agencies, including employers across a range of settings and for all age groups, from birth to death, taking what is called a life course approach. Quote, "There is no health without good mental health." At its heart is the aim not to separate physical health from mental health, to see the mind and body as one, to understand the poor mental health affects our physical health and vice versa, and that things are good for our physical health are good for our mental health. We are social beings, and what creates good mental health and improves the lives of people living with and recovering from mental illness are good social solutions and actions. So addressing the key social determinants of health is key: decent jobs, homes, friends, and being debt-free. So that's quite sort of powerful. I guess the question is, as we start to think about that, how does that relate to what you're seeing in the way you're planning and you're thinking of that from an NHS point of view? And I'll pose that question to you, Janet.
Yeah, so I think from what you said in that speech then, we're all in this together. We're all from different sectors, but it's not a one single organisation approach and solution to this. So we've all got our part to play. From the NHS perspective, yes, it's key. All that's what you've said in that speech is absolutely key. And we're trying to do it from a system-wide approach. So within Lancashire, we're working in mental health. We're kind of working at an ICS system. So we're looking at the kind of macro environment, and then we go into geographical and then to local. So it's not a one-size-fits-all, but there's economies of scale, and we don't want there to be a postcode lottery in that. So, and that's how we're reaching out to people in like our areas. So, did you want to add to that?
Yeah, sure. And I suppose I think for me, what population health means, there's an analogy for my practice day to day. I think we all spend a huge amount of time doing the best we can to make health services we can as safe as we can, as efficacious and as high quality as we can. And I think sometimes what gets lost in that is that we wouldn't need to provide such an amount of healthcare if we paid a greater proportion of our sort of resources into the wider determinants of health. And that could be really simple things from sanitation all the way through to how you help big employers make their workforces more healthy. And so I suppose as well as addressing the supply of healthcare in terms of amount and quality, it's probably much more powerful and economic to address the determinants of health nationwide.
Yeah, I think of it, and coming from outside the space, as someone was talking about it the other day, is I think everyone is working. Think of a ship with a hole in it, and everyone is working absolutely flat out to bail out the water, and we are struggling to keep going. And the question is, and I think there is no one out there who thinks at the moment there is enough supply to meet the demand. There aren't enough resources, and I think this morning we heard about for young people. Yes, we have moved from 25% in the last couple of years to young people who need mental health getting support to 30%. But that's still, as was discussed this morning, 2/3 that aren't getting support. So I think that we absolutely all have to work together, and it's interesting when we're looking at the title, and the title said prevention versus cure. I think that's wrong. As I thought about it on the train this morning, it's prevention and cure, and it's how we work together to do that. But we have to start thinking about how we start to reduce the size of the hole that's letting in water, and that is where population healthcare for me is it plays a key part, and as you say, we're all in it together.
Yeah, and I think it might be interesting to add when we talked about the cost of prevention, the GP cost. We've just done some costings within our system, and this is the top end of the scale. But if you kind of can prevent somebody early days, if somebody commits suicide, it's like 1.5 million to the system. So there's huge savings, and I know that's the top end of the scale, but that's the savings to the system per person. So it has cost benefits, but I don't want to get away from the human factor. At the end of the day, there's a person there that just needs our care and support.
So from an NHS point of view, from what you see, what has changed and what needs to change to make this a reality? And I'll put this in context. When I first started talking to people, especially a lot of people who were, I would say, bailing out the ship, and we'd talk about the idea of prevention versus treatment. Often I'd hear the comment was, well, I am only given money towards treatment and I am only measured and rewarded on treatment. So I think there is the system is changing, I believe, and has to change. And be interested in your thoughts on that.
So I think the system is changing too slow, personally. Strangely enough, I read the CQC report on mental health and the summary of it yesterday, and I don't think we're as far advanced as I would have liked. We've recently done a big ad hoc request from all our third sector providers and our main provider for mental health services, and the issues that have come from that were here like 3 or 4 years ago. So we're still on that journey. I think, so people are saying we're still doing to them and not with them, so I think that's kind of a key factor for me. With regard to services, we haven't gone 24/7 apart from the likes of Big White Wall and another kind of children's digital service we have. So for me, it's extended hours because people aren't just poorly between 9 and 5. So it's a lot of system factors to build up to give that kind of better service for people. There's huge numbers, and it's leadership. So our main trust, we've spoken to some of the staff within that, but the behaviours are being driven by key performance indicators. So we need to kind of look at those. So there's so much work to do, but I do think we're on the right pathway. The NHS, Department of Health and Social Services, are saying the right things, and that's kind of filtering down. So within Lancashire, we're working an ICS system. We're just piloting it within mental health, like the acutes and GPs aren't working there yet. But we've got the network, so it's linking up with networks as well. We've got a lot of peer-to-peer support in mental health. We've just opened a service, which is 7 days a week, 11 to 11, because a lot of people who go into crisis turn up at A&E because they've nowhere else to go. So it's, filling all these gaps. It's listening to what people want and putting in services or support to address their needs. Okay. So it's huge.
It's a big task, and I think going back to we're all in it together and how we do it. So from a practitioner's point of view and from a clinician's point of view, I know you've been, and part of the conversations we have is around what can be done to drive population health. So what are the things that are most impactful in terms of really having an impact on achieving this goal? Yeah,
sure. So I guess I'd like to sort of draw an analogy from the work in sport. And I think, so sometimes in sports teams I'm asked to help an individual be more resilient and to lower the risk of that person having a mental health problem. And I think one of the biggest myths about that situation is that it's a one-to-one piece of work, when actually the reality is it's much more about the environment and the culture in which that athlete exists. And changing that is much more powerful than doing a one-to-one intervention. And so moving that into a population level, I think we know that is true also. So in terms of the research that there is about individual resilience, we know that environmental factors are really, really important. And so that might be somebody's employer and the kind of culture in which they work. And I was reading recently rereading recently the King's Fund vision for population health. And I noticed in the second page of there, they sort of summarise the evidence in an infographic form. And in terms of the most powerful things, the things that are most effective to change, the individual lifestyle factors and individual demographic details are the least impactful. And above that is social and community factors. So community connectedness, the availability of social support, the cohesion of communities in which people live, the extent to which there's inequality in our society. So these things are much more powerful determinants of mental health than other things. And then above that, still we've got major issues such as employment levels and I guess a national quality of healthcare services. So, yeah.
Okay, thank you. So, I mean, I think you brought the idea of community, and I think, it was interesting seeing, I really liked the slide from Andrew this morning that talked about all the factors that really drive mental health, and in that you saw things like social identity and community and stuff like that. And I think it points, and I think Gregor at some point says, we can't simplify what is a very, very complex issue, okay, in his answers. And that slide to me really did that. But I think, one of the questions I have is, there seems to be this theme around friendship, community, and social. So, obviously from our perspective, we're strong believers in the community, and I'm interested to sort of get your thoughts on that, Tim, as and Janet, on sort of where community plays a role in this and how that can work.
Sure. Well, I remember discussing this a bit with you when we first met, and I think as clinicians and as people who provide population health or individual health, we like to deal in evidence, and so there's, I think, a lot of interesting evidence about the power of community and peer-to-peer interactions in terms of health. And I suppose going way back 30, 40 years, we can look at Project Match and the biggest sort of scientific studies of people treating people with alcohol problems. And we find that the intervention that evaluates Alcoholics Anonymous in terms of community and peer support there is just as effective as other kinds of interventions that they looked at. And then we fast forward, I suppose, to about 10 years ago, and in the NICE guidelines we know for a decade now that it's been recommended that peer-to-peer support is a part of treating people with depression who have chronic health problems. And so that's, I suppose, 10 years ago. But I suppose more recently we have technology changing all the time, and in recent years, there's really interesting evidence that I found really interesting about how online technology and online connectivity can have an effect on our sense of connectedness and our sense of social inclusion and our ability to, I suppose, seek help and support in new and different ways, and also reaching people who might not otherwise be reached by virtue of their use of technology.
Yeah. How are you, outside, obviously, Big White Wolf, it's not to do that, but are you doing anything around communities and stuff like that you find really powerful?
We are, and again, it builds on the fact that people recover better when they're treated when they've got that peer-to-peer support, when they engage with the communities. So we're kind of working on building up our community networks. We've just opened another service, Community Restart. We've got community asset development in there, so they're establishing all the groups because of the success, the recovery rates with people who engage in that groups. And for me, I liken it to like my son who's 17, who won't listen to a thing I say, but his peers, and he's just like he latches onto their every word, and it's that kind of ethos. And so we're just building on the community to keep people safe, to keep people well, to stop them going into crisis, stop them tipping up at ED. And that's kind of the approach that we're taking.
Yeah, I find it interesting. So we do some work in Canada as well, and I don't know if anyone's aware, but in Canada, I think because of this disbursement of the population, they obviously have a real challenge of getting resources in the right places for people. And they are really doing some very interesting things around peer-to-peer and leveraging peers in the community to do that. So I think it is, for me, it's something that is, it is eminently scalable, whether it's through technology or outside technology, is an asset that we should be using. So, final question, and then we'll open it up to the floor. The role of digital. You're right at the forefront of this.
Yes.
Transformation. What's the
transformation?
Health transformation manager, right at digital. What do you see about the challenges? The pitfalls of digital. So
it's just a must-do for me. It absolutely is a must-do. It's 24. I can tell you the benefits. You know all the benefits. It's 24/7. It's the immediacy of it. That's the way the generations are going, even the older generations are tapping more into the digital world than probably we realise. And I know Emily can probably tell us this, the kind of take-up of like Big White Wall and other digital services as well with like the older age group. That's growing at a fascinating rate. But we can't get left behind in this discussion. We just got to keep up with it, keep up with the pace. And for me, it's just a must-do. Just a must-do.
Any thoughts on that? Or?
Yeah, I think scale is really important, isn't it? Because I think the figures for the number of people who are able to access iApt, just as one example, are really striking on it. There's a huge gap, and something needs to be done, whether it's digital or something else, but something needs to be done to help reach those other people. I think the thing that really interests me about Big White Wall, I suppose, is the anonymity side of it, and I come across the stigma of mental health every day. And I think one of the things about population health, certainly for mental health, is about how we change the culture of speaking about mental health. And I think that there's the potential for digital to help with that, both by enabling people to access things more anonymously if they simply can't overcome stigma, but also because the more people interact, the more people share or speak about mental health online, or the more visible that is, I think that actually has an effect on changing culture potentially. I think we see more and more big, high-profile figures talking about their own struggles through difficult moments, and I think that really, really helps. I think it happens slowly, but I do think that the stigma, the issue of stigma, is changing, and I think digital has a big part to play in that personally.
Anecdotally, we see that, I'm not sure, and I'll probably get the number wrong, but probably about a third of the people, when they talk about wellbeing gains, talk about that whilst we're an anonymous platform, this has helped them then go on to talk to family and friends about their problems. So actually, this has been the first point where they actually start the conversation, and then they feel comfortable to take the conversation forward. So I think that's a very powerful. It gives them the way in, it catches them early, and it allows them to go and talk to others. So at that point, I am going to open it up to questions. If we've got any questions from the group.